Today I was asked to talk about ultrasound of thyroid nodules. It's my kids. I always show a picture of my family. This is in Florida. These are my daughter, my youngest. This is my wife and my oldest. Um, Ultrasound of thyroid nodules. Nothing to disclose, nothing to declare. What we're going to talk about, this is a series of lectures I give to the residents. It's about 4 lectures. I try to condense them. There may be some redundancy, but we'll try to get through them. So we're going to try to describe the ultrasound features of malignant and benign nodules. We'll review the guidelines for management. We're going to review specifically TIRADs because that's what we use. We're going to discuss ultrasound elastography. And then we're going to talk a little about ultrasound-guided FNAs and how we do it and how to kind of. You have to have really good equipment for to do ultrasound. You need to have really high-frequency transducers. So at least 8 to 20. We have very good equipment at all of our hospitals. And now that ultrasound equipment is getting, I guess, relatively cheaper and better, you could probably even have it in your offices now.
We do have one in office.
You do?
We routinely do FNA.
Oh, okay. For the thyroid is a really, because of its location, it's a very good organ to evaluate by ultrasound because it's very superficial and you can use really high frequency transducers. We use color Doppler and power Doppler to detect vasculature and then adjacent vascular structures. Exam preparation, there's no need. There's nothing. So the patient doesn't have to be sedated. We don't have to draw labs like GFR. Unless you're doing a biopsy, then you may want to check coagulation. The anatomy, it's very well demonstrated on ultrasound. You can see here, so you can see the thyroid gland is very nicely depicted here, left lobe, right lobe, and the isthmus. And then you can see the strap muscles, the sternocleidomastoid, and you can see the vessels very well, the carotids. And here's the trachea. Here's the right lobe here. So the anatomy is very well demonstrated on ultrasound. We have to define what a thyroid nodule is, first of all. So a nodule is really any area of the thyroid with a different ectotexture to the surrounding thyroid tissue. But most nodules are not really tumors. They're not tumors in the sense that they're usually hyperplastic nodules, so reactive changes. And they're usually incidentally detected. So this is a hyperplastic nodule, typical in the right thyroid lobe. Here's the normal thyroid gland around it. So the most common nodules would be the hyperplastic nodules, about 70% at least. Benign thyroid adenomas, maybe 5 to 10%. Thyroid carcinomas, those are the ones we're trying to detect. Okay, so that's about 5 to 15%. And out of those, papillary is by far the most common that we'll see up to about 80%. And then there's the follicular type, the medullary type, and then anaplastic, very uncommon, but thank goodness because it's the most aggressive. You can also have focal thyroiditis, which is not truly a thyroid nodule, but it can mimic a nodule. And then they're very uncommon intrathyroidal, parathyroid cysts, etc. So the prevalence of thyroid nodules, we know they're very common. So if you look at the literature, up to 8% of adults greater than 50 have a nodule by palpation. But if you go by ultrasound, greater than 50%, some studies show 68 to 70% of patients over 50 will have a nodule. So we're going to see a lot of nodules. And by autopsy, about 50% will have a thyroid nodule. And then we know that the prevalence increases with age. So here's a study that was done showing you that by ultrasound, and this study actually only looked at greater than 5 millimeter nodules. So this 68% may even be higher if you included less than 5 millimeters. And then by autopsy, 50%, and palpation, pulling up the rear at 8%. If you compare ultrasound with palpation, you can see that palpation alone can miss a lot of nodules. If the nodule is less than a centimeter, you're missing 94% of nodules. and 1 to 2 centimeter, about 50%, and then greater than 2%, you're even missing 42% of nodules that are detected on ultrasound, and you're missing by palpation. And we know that the prevalence of nodules increases with age. So as you get older, you're going to get more nodules, okay? And palpation, you're getting more nodules, but it's less so than what you would see by ultrasound. So, and we know that palpable and non-palpable nodules of the same size have the same risk of malignancy. And the incidence of nodules are increasing. And the increase is really due to more imaging. So these are like incidental nodules we're picking up. So a patient will have a CT of the chest, will pick up an incidental thyroid nodule, or they'll have a carotid ultrasound, we'll pick up an incidental thyroid nodule. So the true incidence is probably increasing mainly due to more imaging rather than a true increase in the number of nodules. Incidence of malignancy within these nodules, it can be up to 12%. So here's from cancer.gov, it's just the latest one, showing you thyroid cancer. It's not as common as the like breast or prostate and lung, but it's still 43,000 cases, estimated deaths 2,200. If you look at over time, so here's the thyroid cancer, we can see that the number of thyroid cancers over the past few decades have been increasing, especially starting maybe in the 90s. And that's because of imaging. So we're imaging more, we're picking up more, makes sense. But look at the death rate. It's leveled basically the same. So we're picking up a lot of cancers, but nobody's dying. So the issue is, how do we're picking up cancers, but probably, quote, overdiagnosed cancers, okay? So again here, we're picking up more smaller papillary cancers, and it's because we're imaging more. And then a large fraction of these cancers, they represent overdiagnosis. What we mean by overdiagnosis is that the diagnosis of tumors that are unlikely to cause symptoms or death during a patient's lifetime. So how do we handle this dilemma, this epidemic of nodules that we have, that we incidentally pick up, that are, vast majority of them are not going to be clinically significant? So we can use ultrasound to help us to characterize these nodules and to stratify these patients. So we can divide it up into suspicious, mildly suspicious. So suspicious ones we biopsy, the ones that are mildly we can either biopsy or active surveillance. And then the benign ones we probably can follow up or leave alone, and then benign, leave alone. So we're going to go through the features of a malignant thyroid ultrasound. That's what we're going to start with, okay? So these are all the features that are described in the literature. Some of them are good, really good, some of them are not so good. Okay, so let's start off with microcalcifications. This is probably the best feature. So microcalcifications, they have to be tiny, they say less than a millimeter. I'm not going to go measure a calcification. You gestalt it. It's less than a millimeter and has no shadowing. And basically, it's a punctate extrinsic focus without any shadowing. And it's most commonly seen in papillary thyroid cancers. What they represent pathologically is the seminal bodies that can have little calcifications in it. And this is a very specific feature of thyroid malignancy. The specificity is up to 95% in the literature. Sensitivity is not as high because they may not have, at least we may not detect the calcifications on ultrasound. Here's just an example. Here's the histologic slide. This is the calcification. And here's the nodule. This was a papillary thyroid cancer. You can see all these tiny microcalcifications without any shadowing. Here's another one showing you these punctate extrinsic foci, no shadowing, and then here's the histologic slide. Another one showing you, so this thyroid, you can see it's very lobulated, it's it has these tiny punctate calcifications without shadowing. Coarse dystrophic calcification. So this is a different type of calcification. So these are calcifications that have shadowing behind them. Okay, so, and Usually they're seen in multinodular goiters because of tissue necrosis, and you get this dystrophic type calcifications. But if you see them in a nodule, especially in a solitary nodule, then you have to be careful, because those could be malignant nodules, in one study up to 75%. So again, they're dense calcifications with shadowing posteriorly. And they're the most common type of calcifications that we see if it's a malignancy would be medullary thyroid cancers. So here's a classic example. Here's a CT showing you the thyroid here. There's a calcification here. And then here it is on ultrasound. You can see the calcification and there's posterior shadowing. And this was a medullary thyroid cancer. Marked hypoechogenicity. So the echogenicity of most cancers are going to be dark with respect to the rest of the gland, okay? So when you compare it, you can compare it to normal thyroid tissue. And the sensitivity is about 87%, but specificity is still relatively low. But if the nodule is really, really dark compared to your strap muscle, so if you compare, here's the strap muscle, and it's darker than strap, then your sensitivity, your specificity goes up. So that's a very specific sign of a thyroid cancer. Make sure it's not a cyst though, because those could be really dark. So just showing you, here's the normal thyroid here, and then this is darker than the normal thyroid. Again, here's normal thyroid, and so you compare it to normal thyroid, and this is dark compared to the normal thyroid. Now, if it's really dark, here's the strap muscle here, and here's the sternocleidomastoid muscle, and this thing is really dark compared to so this is considered marked hypoechogenicity, which is a very strong sign, and this is from the literature, and this was a papillary thyroid cancer. Here's another case, hypoechoic compared to the strap muscle, so this was another papillary thyroid cancer. But echogenicity by itself doesn't mean anything. Here's a case of an isoechoic papillary thyroid cancer. So just going by echogenicity alone, you can't rely on that. Taller than wider. So we talk about taller than wider. So if you measure the AP diameter, you always do it on a transverse imaging, by the way. Okay, so you measure the AP diameter, and then you measure the transverse diameter. And if it's greater than 1, then that's one of the signs of malignancy. It has a 93% specificity, but sensitivity is not as high. Usually you'll see it more in smaller nodules, which may not be a significant nodule, but either way. The theory is that as a nodule grows, if it's malignant, it'll grow crossing tissue planes if it's a malignant nodule, whereas if it's benign, it'll just grow between the tissue planes.
Just to clarify, Doctor, the nodule is smaller than a centimeter, the taller than wide is not as significant.
It's not as significant because the nodule could still be malignant, but if it's less than a centimeter, it may be a quote overdiagnosis nodule. But so we don't only look at one feature; we look at the whole thing, including size. So here's taller than wider. So on the transverse plane, you can measure there to here and here, and this is taller than wider. Here's one. This was a thyroid cancer. You can see it's taller than wider, what we would look for. Irregular margins. So irregular or lobulated margins is another sign of malignancy. And you're comparing it to the adjacent thyroid parenchyma, and it has sensitivity, specificity all over the place. So, but it is one of the features we look for. The problem is it has high interobserver variability, and then all of the nodule, part of it may be well-defined, part of it may be irregular. So there's really a lot of interobserver variability. So this one looks relatively irregular. Here's some that I'm showing you. Part of this looks pretty regular, and then this part looks irregular. So, that's why there's so much interobserver variability. Here's one that's lobulated. So this, question, it's got one lobule here, another lobule here, etc. So pretty easy one. Here's one that shows, again, well-defined here, but then irregular margins posteriorly, so another one that can be difficult to assess. Here's one showing you more irregular kind of the margins here, part of kind of infiltrating into the the normal thyroid gland. Another one showing you more irregular posteriorly here. Intrinsic vascularity. I mentioned this one because this is lost. This is probably not a malignant feature anymore. It was first described as one. I'll show you something. So original studies said that, okay, if you had a lot of vascularity, it's a high chance of malignancy. But newer studies have shown it's probably not a good sign. One of the later studies showed that benign nodules still had 57% and malignant nodules had 40%. So it's a coin flip. So we don't use this anymore. So vascularity by itself is not, but it was originally described back when I was a resident. Here's one showing you papillary thyroid, very vascular. But here's adenomatous hyperplasia, very vascular. So it's a coin flip. Here's papillary thyroid is avascular, or relatively avascular. So, and here's another one. Here's a papillary that's relatively avascular. So vascularity is not. You're just going to read it in the old literature that but for our purposes, it's no longer a feature. Direct tumor invasion. That's a feature that's, if you can see it, then it's a high index of suspicion that it's malignant. So what happens is you have tumor invasion to the adjacent structures outside of the thyroid. It's a very rare finding, but it's a very specific finding. You can even have sometimes, and these are usually an anaplastic type of thyroid cancers, where they invade the trachea or even the larynx, and you can have recurrent laryngeal nerve or the esophagus. And again, these are very large anaplastic cancers, and there's not going to be any problems diagnosing the malignancy. And there's disruption of the capsule of the thyroid gland. So this was an anaplastic cancer. You can see this is a huge mass here, and you can see it's invading posteriorly here along the prevertebral soft tissues. And the mass is so big you can't even fit it on one ultrasound image. It's a split screen image. This is a smaller one showing you that here's the strap muscle here, and this mass was extending into the strap muscle here, invading the capsule. Here's part of the capsule, but then you lose the capsule anteriorly. Nodal mets. When we do thyroid, we don't specifically look for nodal. We probably should. We see it incidentally if it's there, but that's a good feature. If you see abnormal lymph nodes, that's a high chance that the nodule on that side is a malignant nodule. But again, it's not a very common finding. It's reported in anywhere from 19 to 61% of thyroid malignancies. Again, it's a specific sign, but not very common. What are the features? Size. We use 7 millimeters in short axis, or other people in the literature use it, but 7 is sort of what most people use. Rounded, because most lymph nodes are elliptical, so when they change their shape, it's something we look for. The fatty hilum is something we look at. So there's usually an echogenic fatty hilum. If we lose that fatty hilum, that could be a sign of malignancy. Irregular margins, calcification. So calcifications in lymph nodes in the chest, very common. Granulomatous disease, easy diagnosis. Calcifications, lymph nodes in the neck, not granulomatous disease. We've seen a case of TB that did it, but you see calcifications, lymph nodes in the neck, look for a thyroid cancer. All right. Cystic areas, cystic lymph nodes are always bad, okay? And for lymph nodes, increased vascularity is bad. So in one study, if you had nodal mets, specificity is very high, 99%. Sensitivity is very low, though, because we hardly ever see it. Central lymph nodes are much more common than lateral lymph nodes. So if you look at this from SOM, you can see the lateral versus the central. So 6 and 7 would be, and we usually don't even image the 7 because that's super stern under the sternal notch, and we can't get an ultrasound probe there. So, but 6 we usually will be able to see that area. Here are some examples of malignant nodes. Here's this lymph node has some calcification. You see this, these tiny little echogenic foci, and there was a little bit of shadowing. Here's a cystic lymph node. Cystic lymph nodes are never good. Here's one that's mixed cystic and solid. So when we see this, we are suspicious that this is malignancy. Here's showing you, here's the thyroid cancer itself, and here's the lymph node. And you can see that it has septation, and most of it is cystic. And here's on CT here, cystic appearance of the lymph node. Vascularity, here's showing you a very hypervascular lymph node here. And here it is on CT. This is the lymph node that's enhancing brightly. We have to talk about the benign features too, because malignant features fine, but if you have a specific benign features, then you can say, okay, don't touch. This is benign. So we'll have to we need to go through what are the benign features because we don't want to obviously do too many biopsies of these. So, but to be benign, you have to make sure that it's benign. So you have to have really high specificity. You don't want to say something is benign and it turns out to be malignant. So you want to have very high specificity. You're sure that this nodule is benign. So there were a bunch of studies, one by Bonavita, that showed that if you can detect these benign features, you don't need to biopsy these. So these are the benign features that are described in the literature, and you've probably seen some. Spongiform, we'll talk about that. Cyst with a colloid clot. I don't like this one, but it's in the literature. Giraffe's hide. I don't make these things up. These are what they're called. We'll talk, diffuse hyperechogenicity, and then comet tail. That's a really good one too. And if you see this, there was one study that said 100% specificity for benign. I don't believe in 100%. Nothing's 100%. Maybe taxes. But anyway, we don't. There's always a case you're going to say, oh, this turned out to be malignant. And then there's another hypococ halo. I don't really use that a lot, but it's in the literature. So let's talk about spongiform nodules. So these are microcysts, so tiny little cysts, and they have to occupy greater than 50% of the nodule for you to call it a spongiform nodule. And characteristically, they're in hyperplastic nodules, and they say the risk of malignancy is less than 1%. So here's these tiny little cysts, and you can see that these tiny little cysts occupy this nodule here. Here's another example. Tiny little cysts occupying more than 50% of the nodule. Here's another classic one. Tiny little cysts occupying. So these are spongiform nodules, and they're characteristically benign nodules. Here's another from the literature showing you tiny little cysts. And the vascularity, the septations or whatever, they can't have vascularity, so that doesn't mean anything. Again, here, these tiny little cysts. These ones had tiny echogenic foci, which we'll talk about in a second. Here's the cyst with colloid clot. I don't like this one, but it's basically a cystic nodule with retracted. They talk about avascular colloid plug. There's no significant flow in the solid component. But so if you look at this looks like a cyst, and then this looks like a spongiform nodule in a cyst. So here's another one. So if you just took away the cystic part, this would be a spongiform nodule. So this is typically benign. So this would make sense. But don't get confused with this. This is a cyst, and this is a nodule, but this is a cancer. So that's why I don't like this colloid plug thing. So you make sure that your solid component, whatever you're saying within the cyst, is not solid. It is spongiform. Does that make any sense? Okay. So don't confuse this with this. All right. Giraffe hide, basically these are hypercortical foci separated by these bands. This is very classic for Hashimoto's thyroiditis. So, you see this, it's sort of a classic appearance. This is really, I mean, if the whole gland is like this, I'm going to call it a nodule. So, but this is what they've described in the literature. Another one, here's another Hashimoto. Again, this is truly a nodule with sort of a giraffe hide appearance. And this is a benign nodule. Diffusely hyperechoric, again, if it's very, very bright, it's been classically described in Hashimoto's very, very bright nodules. Another one, very bright nodule. The hypochoric halo, I don't like this feature. It's in the literature, so it suggests it has a specificity of 95%. But you really have to look at the entire nodule. If you're just giving me one image, you could say, okay, the whole thing. But it can be, the problem is that if you don't examine the entire halo, you could be missing part of the nodule, okay? And it's thought to represent normal compressed parenchyma. So here's a benign nodule, nice hypochoric halo around it. Here's another, this was a follicular adenoma, a nice hypochoric halo. Here's another one, hypochoric halo. The problem is that, part of the halo may be hypochoric, and then here you lose it. And this turned out to be a thyroid cancer. So I don't like using this unless you're really comfortable and really, you go in and scan the entire. And here's a thick halo. So this has got a halo, but it's thick, and this was a papillary thyroid cancer. So this, I don't use that often. It's in the literature, but I don't use it. Comet tail artifact. This is a very good sign of a benign nodule. It's got, according to literature, it's 100% specificity for a benign nodule. So what it is, it's basically colloid within a nodule, and it causes this reverberation artifact. So you can see the echogenic foci, and then this kind of comet tail that's behind it, and it's a very classic sign of a benign nodule. So it's basically colloid microcrystals. Sometimes you can mistake them for microcalcifications. So, like this one, it doesn't really have that good a comet tail. This has a nice comet tail. So you may mistake it. You may say, okay, it's not, and it turns out to be. But it's better to do that than to be on the other side, right? So here's the classic comet tail reverberation artifact. Here's another one showing you the echogenic foci with comet tail artifact. Again, another echogenic foci, and then reverberation artifact. The problem is that you got so many of these, and then you got some of them that show this, and then some of them don't. So you got to be careful, because you can have a cancer with some colloid in it. When you have this many, you have to be careful that you're not going to miss a cancer. In fact, this was a papillary from the literature showing you some of them had comet tail, some didn't. So if you see it and you're sure, then it's a good sign. I want to talk about ultrasound elastography. So we don't do this specifically, but it's in the literature. It's I guess it's relatively new. It's not that new. It's probably about less than 10 years old. It uses ultrasound imaging to quantify the ability of the tissue to be deformed when you apply pressure to it. So basically, we know that malignant nodules they're denser, okay, than benign nodules. So when you try to compress them, they're less compressible. They're stiffer. So you can use ultrasound to quantify this stiffness or this, and you can try to determine whether it's malignant versus benign by its stiffness. So there are really two types of ultrasound elastography. strain imaging, so I'm not going to go into physics, but the strain imaging, that's old, that's qualitative. So this is where the sonographer, when I was a resident, they would compress, but you got a strong male sonographer. I can compress, he can compress anything. He can compress my thyroid to the back of my head, right? But, so it depends on how hard you compress. You can compress anything as hard as you want to. So that's really qualitative, and it's really operator dependent. So this is not a very good technique. But then shear wave came about. So what you're doing is you're sending in a acoustic pulse, and that causes its own compression from the sound waves. And you can measure the relaxivity of the tissue, and you can give a measurement of how stiff that that lesion is, okay? So shear wave is a much better technique. So if you look at the literature, it says that it's conflicting, it's all over the place. And that's because they mixed shear wave with compression. So you can't compare, you got to compare apples to apples, okay? So, but if you just used shear wave rather than strain, your results are much better, okay? So we'll show you. In one study, they showed that if they used a cutoff of 42 kilopascals, so stiffness or of 42 was their cutoff line, they had a pretty good performance of sensitivity is 85%, specificity, 94. That's pretty good. I mean, anything over 80 is really good. So I'm just showing you from their literature, showing you there's this nodule here. It's cystic and solid, so by itself you wouldn't know what it was. But then if you did the shear wave elastography, it came out to 83%, which 83.5 kilopascals, which is over their 43. So this turned out to be a thyroid cancer. Here's some cases from the literature showing you this. Basically, this color map, you can flip it, whatever, but they usually use the softer is red and harder is blue. So this is hard compared to the rest of the thyroid. So this was here it is on grayscale. This was a thyroid papillary cancer. Another case here, this nodule here, relatively hypochloric nodule. You can see it's very hard, and this again turned out to be a papillary thyroid cancer. Another case, papillary thyroid cancer, very on shear wave elastography. Showing you that benign nodules. Here's a nodule here. It's got this. Most of it it's very soft, and this was a hypoplastic nodule. Showing another nodule. It's by shear wave. It's relatively bland. They flipped the scale on this side, so red would be hard, and then so this is relatively soft. You can see it on grayscale. Here's a medullary thyroid. Again, the scale got flipped back again. So this is red means it's very hard, high kilopascal, and you can see that this was from the literature. For benign cysts, you can see that again it's a shear wave. It's very soft. Another papillary, just showing you some examples. You can see here. Part of the nodule is not as stiff, but most of it was. Another hyperplastic nodule showing you how shear wave can help you. I think it's beneficial for multinodular goiter. So you have 5 or 6 nodules. You can't figure out, it's hard to figure out what's what. If you put the shear wave, it may help you because then you can tell which one is the stiffest nodule in the gland, and I think that's where one of the benefits it can be. Instead of looking at each individual nodule, you can just put a shear wave on top and then figure out which one is the stiffest nodule.
Is that something you could add in future to pre-existing ultrasound, or you have to get it?
Yeah, so right now we don't do these because we do have elastography, but we don't have the thyroid package. We have it for liver, That's all we have for. It's actually liver. So we'd have to purchase this separately. This is just showing you this was a multi-center study that published in 2016. They looked at all of the signs, and it showed that if you have irregular margin microcalcifications, that was the best feature. They had stiffness, but then this was mixing up both shear wave and strain, so that's why it wasn't as good. And then for prediction of benign, they showed that stiffness, if it didn't see stiffness, then it was a good sign. And then simple cysts were the most hyperechogenicy. So I'm going to switch to guidelines for thyroid nodules because I think this is important. Initially, we had the SRU, the Society of Radiologists, so they had guidelines that was published back in 2005, and that's what we used for. I used it for like 20 years. This is what most of we were using. ATA has its own guidelines. I don't know if you use those. We'll just briefly touch on those. And then TIRADS, which is the new. It came out in 2017, and then more and more radiologists are using it. And I think this overall is the best guide. And then there are a bunch of others, European thyroidists, and even the Korean Society. And basically, they're very similar in respect to their guidelines. Just to touch on the SRU, because this was really the first guideline, and we used it a lot, and how to manage. It was based on a consensus conference that they had. Bottom line was for nodules 1 centimeter or larger, if it had features, if malignant like microcalcification, then if it was greater than a centimeter, they'd biopsy it. Greater than 1.5 other features, and then greater than cystic and solid. So they stratified it 1, 1.5, and 2 centimeters based on how malignant they felt the features were. Very simple, easy to use. You didn't have to give a points or whatever. The size was a factor because they didn't want to overdiagnose thyroid cancers that were so size was very significant, and they didn't want to biopsy all these nodules that, especially if they're not significant. Okay. Then the ATA 2015, I think that's your latest, right? I don't know if it was revised. So really the ATA, it's good in that it uses like what the nodule looks like. So it's basically visual, which I think is good. The problem is, what if you have a nodule that doesn't fit into one of these high, what if it's in between? It gets confusing sometimes, and because not all nodules fit into a nice category all the time. So, and then they go through this algorithm, which is what to do. So TIRADS, so this is taken from the ACR.org and ACR TIRADS, and a lot of the images are from Radiopedia, which is a good source if you guys want to look at all these, a lot of them, and Radiology Assistant is a very good website, gives you a lot of path-proven ultrasound images. So the guidelines were published in 2017. It was basically, they convened 2012, and they wanted to provide recommendation reporting of these incidental thyroid nodules. As we know, there's so many of them, right? So they developed this lexicon and reporting, and TIRADS is based on basically BIRADS, or breast imaging. That started the whole thing, right? So now we have TIRADS. We also have LIRADS and PIRADS and everything, okay? So why do we need a new system? Well, again, we mentioned this. We know that thyroid nodules are very common. Remember, we said up to 68% of adults are going to have a thyroid nodule. So, and then you can't biopsy all of them. And FNA, we know that's the best test to determine whether the nodule is malignant. However, we know that the vast majority of them, especially the nodules that are less than a centimeter, they are either benign or they are, quote, even though they're malignant, they're non-aggressive malignant. So you're going to die of something else rather than the cancer. And we know that there was one study that said that overdiagnosis, especially in the United States, that's just the diagnosis, which is the diagnosis of thyroid malignancy that would not, if left alone, cause any death. And that accounted for 70 to 80% of thyroid cancer cases in women and 45% in men. And this was between 2003 and 2007. So that's a lot of cancers that didn't need to be treated. That probably, we should have just don't do anything. So the thyroid calcification was developed to try to figure out which ones we can leave alone, which ones we need to biopsy and take out, and which ones we can follow. All right, so this was all done. A lot of the information is on thyroids.acr.org. Anyway, it used this information was from the literature and also from the Sears. They did have a disclaimer. They always have a disclaimer. They don't want to get sued, so don't go back and sue ACR. So this is a guidelines. It's not a standard, okay? So this is what our guideline is, and even, so you have to treat the patient as a patient, not a picture, all right? So based on, so you got to use some clinical judgment, or else it'd be too easy, right? And also don't sue ACR. So it's based on what we talked about before. So they had 5 categories. They talked about composition, echogenicity, shape, margin, and echogenic foci. And we talked about these, so we'll go through them quickly. So you have to select, you give a point for first 4, and then for the last, give as many, whatever it falls into, as many, check off as many points as you want to. And then it ranges from benign, which is TR1, with high suspicion as TR5. Okay, so this, I know it's a lot, but this I have on my phone. I can't, I'm not memorizing, well, we've got most of it memorized as you use it more often, but we have this in our reading room. So we put it up, and then we can check off each category and determine a total point based on composition, echogenicity, shape, margin, and echogenic foci. And then based on the points, it gives us a TIRADS 1 to 5, and then based on size, whether to biopsy, follow it, or leave alone if it's smaller or benign. And then it just gives you a little. So this is really easy. It's just a little cheat sheet. We put it up in our reading room, and we know how to use it. So let's go through these categories individually. Okay, let's start. First of all, the assumption we have to make. Sometimes you'll have these calcifications that are rim calcification, and you can't tell the character of the nodule. So if you can't tell the character, is it a cyst that's calcified? You can't tell. So you just say it's solid in that case. And if you can't tell what the echogenicity is, you give it isochloric. So that's your default if you can't tell. If the margins are, you can't tell whether it's a sharp margin, irregular, etc., you give it ill-defined. So that's your default. Okay. Echogenicity, again, if you can't tell if it's hyper or hypo, you default it to iso. Okay, and then composition, if you can't tell if it's cystic or solid, you give it solid. You give it to what it worst could be. Okay, so let's talk about composition. So solid means it has to be greater than 95% of the nodule has to be solid. I know that's kind of hard because what's 95%? I'm not going to go measure it. I gestalt it. Okay, there are some actually ultrasound packages that you can actually measure the cyst component, measure the solid, and then they give you actual numbers, but that takes too much time. And you get 2 points for that. And mixed cystic and solid, you get 1 point. If it's totally cystic, 0. And spongiform, remember we talked about spongiform, you got to know specifically that gets 0. And then if you can't tell, you just say it's solid. Okay. Here's typical cystic nodule. Here's a colloid with a common tail, so typical. Spongiform, as we talked about, benign. Just one thing to remember, everything inside, that'll determine the rest of the categories. Okay, echogenicity, all right? Spongiform, it looks like a sponge. You can see tiny little cystic areas. Cystic and solid, again, the rest of the lexicon, what its exogenicity and is determined by the solid component. Okay. Here's a solid nodule. You can see 2 points. You can just, it's got, this one has a little cystic component, but you can tell that this is greater than 95% solid. Echogenicity, again, you're comparing it to the ipsilateral thyroid gland, and then for strap muscle to determine if it's really hypoechoic. Okay, so 1 point. And sometimes, you know, you're saying, is it iso, hypo? It doesn't matter because they both get 1 point, right? Hypoechoic, then determine if it's darker than the gland, but then if it's darker than the muscle, that's even worse because that gets 3 points. If you can't tell, 1 point. So here's typical anechoic, 0 points. Here's hyper. So here's the normal thyroid. This is brighter than the normal thyroid. It's hyperechoic. Here's iso compared to the normal thyroid, showing you some examples. Here's a little bit hypoechoic compared to the normal thyroid. And here's very hypoechoic compared to the strap muscle. Okay, so, and then you get 3 points for that. You can't tell because this has calcifications, shadowing, I can't tell. So, you know, you're going to give it a solid and you're going to give it an iso. Shape, so this is where taller than wider.
What is the anechoic?
Anechoic.
Anechoic is, it's cystic, so it gets 0. So it's not, it gets 0 points. Make sure it's anechoic because they're, you know, with a high, like, there's some cysts that are complicated, so it's not going to be totally anechoic. They'll have like blood or whatever, you know, material in it. But if you put Doppler, it has to have the, I can't give you an ultrasound lecture. It has to be a well-defined imperceptible wall through transmission and no color flow. Okay, so that's the difference. Even though it may have some echogenicity because of the debris, you can tell if it's a cyst by looking at it by ultrasound. All right, so taller and wider. If it's taller and wider, it gets 3 points. Taller than wider. This is wider than taller, so it's 0 points. This is a benign nodule. It's wider than taller. And here's a taller than wider, gets 3 points. Margins, we talked about this. If it's ill-defined, really you can't separate it from the regular, hard to separate, gets 0 points. Smooth, that's self-explanatory, it's smooth. Irregular lobular, extrathyroidal extension, if you see it, it's 3 points. If you can't tell, it gets 0 points. So here's nice and smooth, 0 points. If it's ill-defined, you can't really tell where the borders are, 0 points. If it's lobulated, so here this is lobulated, this is irregular. It makes no difference. They both get 2 points, but I'm just, you know, just showing you. Lobular, this is more irregular. Here's another lobular, here's more regular. Again, doesn't make a difference, gets 2 points, right? Lobulated, it's regular, you know. Extrathyroidal extension, if you see it, it's bad, so it gets 3 points. You can see here, just showing you the capsule here is invaded. His synochial is invaded. Gets 3 points. Exogenic foci, very important. It doesn't have any, it gets 0 points. Comet tail, remember we talked about that, 0 points. Macrocalcification gets a point. Peripheral calcifications, that gets 2 points. And then the punctate exogenic foci we talked about, that's the bad one, that gets 3 points. So here you can see nice comet tail artifact, that gets 0 points. It's got this reverberation artifact behind it. Here's the macrocalcification because it has to have shadowing. You see the shadowing right here. So that gets 1 point. Here's peripheral calcification. The problem with this, you can't characterize, so it gets 2 points, peripheral with shadowing. And then these are the punctate exogenic foci here, and they get 3 points. So then, so you add up all the points. And if it's a benign, 0, all the way to highly suspicious from malignancy, 7. And then the recommendations are, if it's benign, basically you don't do anything. Thyroid's 1 and 2, that's it, you're done. The patient doesn't need any follow-ups or anything. The TR3s, if it's greater than 2.5 centimeters, then you should biopsy and then follow if it's 1.5, and then don't do anything if it's less than that. And then for the 4s, 1.5 for biopsy, greater than 1, and anything less than that, you don't do anything. And then for the highly suspicious, you go from 1 for biopsy and greater than or equal to 0.5 millimeter to follow. So when do you follow? If it's a TR3, it's 135. If it's TR4, again, it's 1235. And then for TR5, it's every year, annually, for 5 years. And then after 5 years, you stop. That's it. And this is based on the natural history of nodules from Chandler. When you're reporting, you shouldn't report more than 4 nodules. So you report the highest point total, or the ones that require the warrant of FNA or the follow-up. So there are glands that we see has like 7 nodules, right? You can't mention every single nodule. So you report up to 4, but the most suspicious 4. Okay. I just want to talk about growth because what's growth? I mean, anything. So they talk about 20% increase in 2 dimensions. That's what I use. That's the easiest one. Or you can do a volume measurement. That's harder. I mean, they get a calculated, length times width times height times 0.52, and then all this. It's too much work. So just do this one's easier. Or a minimal increase of 2 millimeters. Okay. Again, that's. So this was the risk stratification where they looked at the risk of malignancy versus the point total, and you can see here it's what we expected, right? At high points, you have a high risk of malignancy. But even look at these. These are TR4s here. That's pretty low risk of malignancy. So it's still pretty low here. But if it's really high, obviously the risk of malignancy is high. We have this, it's called a Thyroid's calculator. It's on the web. I have it on my phone. Just you plug in the numbers. Let me see if this works.
The ETA also.
Is it?
And they have for the.
Hopefully I didn't screw things up here. Yeah, so here it is. So you can point, click, is it spongiform, is it, etc. And then you say you see a mixed cystic and solid, well, try this one here. Get rid of this here. Just give me an example. It's taller than wide and lobulated, and then it's got microcalcifications, and then so it's a thyroid. So and it tells you highly suspicious, etc. So it's a really a nice little. I don't know who came up with this. Should have an app really for it. Can make some money. Well, I don't know. So for FNA, the most suspicious nodule, based on size and points score, obviously, will be biopsied. For what about multinodular glands? Well, you should biopsy no more than 2 nodules. Okay, so we should say these 2 nodules. I know some places do. What do you do? Do you do more than 2? Okay, I know some places do 4 or 5 nodules. I mean, that's crazy. I mean. So, but you do the 2, the hot, 2 is the most suspicious, and you can follow the others, right? But believe me, I know some radiologists that do a lot, like 4 nodules, and that's a lot. I mean, the poor patient. I mean, you're lying there for like 4, that's hard. For multiple nodules, if they have similar characteristics or they have this heterogeneity, confluence. Probably you don't need to FNA it because that's probably a multinodular goiter. But again, if you have multiple nodules with a really dominant one that's really suspicious, and that's where I'll see a multinodular gland, and I know this is going to be a multinodular goiter, and I know this is going to be negative. And then they'll say, all right, so this is a TR4, okay, great, and it's greater than 1.5, okay, so biopsy, and I know it's not going to be there, so I might tone it down a bit, but it always comes back. I'll get an email, well, why didn't we biopsy this? And then, anyway, we ended up biopsying. But I'm just saying, most of these multinodular, you get to see these nodules, and you know this is benign, okay? You see it at the VA a lot. This is I know this is benign, but it pushes you. So that's one thing I don't like about TIRADS. It pushes you in a way. But again, it's just a guideline. It's not a standard. Okay. Here's a multinodular diffuse heterogeneity, and this I've seen people biopsy this. I usually just say multinodular goiter, and I don't even give it a TIRADS. But then I get in trouble because I didn't use TIRADS. All right, so let's talk about, got 5 minutes, sorry, 5 minutes. Okay, ultrasound-guided thyroid biopsy I was asked to talk about briefly. So hopefully these are like 4 lectures trying to cram into one, sorry. So we know that fine needle aspiration this is really a minimally invasive, it's really a safe procedure, and it's done as an outpatient. So it's a really, a very good procedure to do. And ultrasound really helps a lot to visualize the needle in the lesion. You know that you're in there. It's much better than palpation. Okay, I don't know whoever does. I guess if it's a huge nodule, but even if you could palpate it, the ultrasound is much better than palpation. From the literature, you know that you're in it using ultrasound. It's the most accurate and cost-effective method for diagnostic evaluation of thyroid nodules. The sensitivity is up to 98%, specificity up to 100%. You can see that depending on who's doing it, I mean, these are very good numbers. Has less false negative results than palpation alone, and lower rates of inadequacy. So what do you do? Pre-procedure planning. So you get informed consent. You get risk of hematoma, infection, very uncommon. I've never had a case happen, but it's in the literature, so you have to obviously inform consent. Do we do coagulation? No, we don't. It doesn't matter. You're putting in a tiny needle, so we usually don't get any blood tests on these patients. If they're on warfarin, yeah, I'll stop it. Some people stop aspirin. I don't stop aspirin. You're on aspirin, fine. You don't stop. But some like warfarin, yes. Here's a case of a hematoma that was from the literature, big hematoma from a biopsy of a thyroid. So it can happen. Patient positioning, they're supine, their neck is extended a little bit. You clean the skin, betadine, and you drape it, and then we use a high-frequency transducer. And you can give local anesthetic. Some people do, some people don't. I think most people do now give local. You use a very small needle, I use a 25 gauge. Most people use a 25 or 27. Attach it to a syringe. You can have a syringe holder if you want to. And then you put this transducer right over the lesion, and then you stick the needle in, and you always do color off to make sure that it's not very vascular, or make sure where the vessels are. And then you have the patient don't speak, don't swallow, and then you insert the needle. So when you obtain, we use freehand technique. I know there are guides that they have, and it's really cumbersome. They make these guides that are, I don't know how people use it, because it's like the contraption is very difficult to use. So your freehand technique is the best. And you can either put the needle parallel or perpendicular to the transducer. And I'll explain what that means. And then you sample, when you see the needle in the lesion, then you sample, okay? And you can sample up to do 5 samples. Okay, so here's a parallel technique. So the advantage of this, so basically the needle is parallel to the transducer. The advantage is that you can see the needle go in real time into the nodule, bypassing any kind of vessels that are in the way. The disadvantage, you need a larger field of view, and it requires a little bit more skill. So here's what parallel means. Here's the needle going into this nodule here, and you can see the length of the needle. And here it is, it's parallel to the transducer. I'll show you what it looks like on a video. So this is what I use most. So here again, here's the nodule. Here's the carotid. So you don't want to hit that, obviously. So you can see the needle got right into this nodule. So you're watching it real time going straight through. Then making sure that you don't hit a vessel that's in a way, because if you hit obviously that's what you don't want to do, right? Here's the perpendicular technique. So the advantage of this is you need a smaller field of view, really less skill, because basically you're imaging and you're sticking in your needle and you're just, oh, well, hopefully I'm hitting something. Where is it? So it's a kind of a less skill is involved. And the disadvantage, you can't see your needle as it's going in. You see it hopefully when it's in the lesion. So I think it's a much more, it's not as good a technique. Here it is perpendicular to the transducer. You can see just the tip of the needle will be in the lesion. And here's what it would look like on video. So again, perpendicular technique. Here's the nodule. And you can't see the needle, but then, bam, you see it in just the tip of it in the nodule. Again, you don't know what's going on above it. So you can limit this to, if it was close to a vessel, obviously you wouldn't want to use this technique. But again, how do I get out of this? Shoot. Okay, sorry. So whether to aspirate or not aspirate, I don't aspirate. So some people say that aspiration is best because then you can actually aspirate the cells into the needle. Non-aspiration technique, you don't put any suction, you just collect the cells by capillary action. I think that's because a lot of these lesions are vascular, so as you're aspirating, you're getting more blood, and then the pathologist, we have the pathologist with us in a room, and it's all blood. And so non-aspiration is probably better, especially if it's a vascular lesion. And this was a study that showed that if you didn't do aspiration, you had better samples versus aspiration. Put a Band-Aid, ice, and discharge. So it's they don't, it's an outpatient procedure. It takes 10 minutes and then half an hour they're gone from the department. I just want to talk about core needle. We don't do core needles. Do you do core needles? I know a few. I know one.
Send it for lymph nodes sometimes.
Yeah, for lymph nodes. Yeah, but there are some that do core needle. I think it's. I've never done it. Some do. It's basically they have these small little core needle guns that they use. It's 16. 16. That's big. I mean, that's what you would biopsy a liver with. I mean, thyroid would be like anyway. But there are people that use these guns. I think they're mostly in Europe. Don't get sued. So it's obviously they're better than fine needle. Of course, you got a chunk of your thyroid taken out, you're going to be able to make a diagnosis. But then the complications are higher, and so yield is better. Complication. I don't do it. Some places do it. I don't. So in summary, we talked about how ultrasound can be helpful in differentiating malignant and benign nodules. We talked about ultrasound elastography. I think it may be helpful. Right now, we're not doing it, but in the future, we may be doing it. We talked about the guidelines, specific to TIRADS, which I think is the best one out there right now. And then we talked about ultrasound-guided FNAs. Okay, that's it.
Your preference to lidocaine injection versus using those creams, which they say use for 30 minutes?
Oh, yeah. You know what? We only use lidocaine. We never use that. Yeah. I mean, I would think, I know we've never used the creams or anything.
Thank you so much.
You're welcome.